percentage of babies placed for adoption are healthy?
So the question that I then in turn ask is, how do you define healthy? So would you consider a child with asthma healthy? Would you consider ADHD? Autism? Is a child healthy if they have a food allergy? A lot of times there's something fearful, right, behind that question. What is that person worried about? And so I try to get to the basis of that and really try to understand what is driving the question. If it's looking for somebody who truly does not have a single medical concern whatsoever, I mean, then the question is really, what is that in general for kids, right? Lots of kids have something that could be labeled as unhealthy.
What do you think they're asking?
I think a lot of it is the fear of the unknown. When I'm talking about substance exposure, which is one of the things I talk about the most often, just don't know what that means. But sometimes that unknown is much scarier than the reality of what we need to think about.
Welcome to the Adoption Roadmap Podcast, your go-to guide through the beautiful, complex, and transformative journey of adoption. I'm Rebecca Gruenspan, a single mom through adoption consultant for over a decade, author of the Adoption Roadmap book, and your trusted guide. In each episode, we dive into real experiences, expert insights, and the raw, honest truths that you will need to navigate your journey. Whether you're just beginning, in the thick of it, or well past placement, you'll find support and community here to help you navigate this unique path with confidence and love. Adoption isn't all rainbows and butterflies. It is life-changing and worth every bit of effort. Let's learn, grow, and journey together on the Adoption Roadmap Podcast. Today, we're diving into one of the most challenging and emotional aspects of adoption, addressing the medical and health concerns that many hopeful families face. Our guest is Dr. Sarah Silvestri, a board-certified pediatrician, adoptive mom of two, and the founder of the Adoption Doc LLC. With her extensive experience in adoption medicine, Dr. Silvestri specializes in educating adoptive families about the complexities of prenatal exposure, birth family, medical, and mental health history, and the gray areas that come with these issues. Dr. Silvestri is here to demystify common fears, from the impacts of substance use during pregnancy to the risks of STDs and genetic disorders, and provides practical, informed advice to help families. That is a whole mouthful, but let's dig in, Dr. Silvestri. And thanks for being here. You have spoken with our different communities for years now, and you're a wealth of knowledge.
Oh, well, thank you again for having me. It's always great to work with you guys.
Awesome. What percentage of babies placed for adoption are healthy? This is a question I get so often. How would you answer that question?
So the question that I then in turn ask is, how do you define healthy?
Amen.
Right? I think that especially as medical professionals, we have a tendency to have a much broader definition of healthy, perhaps, than some other people do. So would you consider a child with asthma healthy? Would you consider ADHD healthy? Would you consider autism healthy? Allergies. How about a fruit allergy? That can be pretty serious. Is a child healthy if they have a food allergy, right? So a lot of times there's something fearful, right, behind that question. What is that person worried about? What are they concerned about? And so I try to get to the basis of that and really try to understand what is driving the question as opposed to what that actual definition means, right? If it's looking for somebody who truly does not have a single medical concern whatsoever, I mean, then the question is really, what is that in general for kids, right? Lots of kids have something that could be labeled as unhealthy. So it's a hard question to answer because there's a lot of different definitions that people may have, and they might differ from one person to the other.
Yeah, what do you think they're asking?
I think a lot of it is the fear of the unknown, right?
Mm-hmm.
And I think that's the biggest thing for most adoptive parents going into these situations. When I'm talking about substance exposure, which is one of the things I talk about the most often, it's really the fear of the unknown. They just don't know what that means. It may not have been something that they've been exposed to before in their lives. And substances have such a strong bias against them and such a negative effect against them that that bias and that negativity can spread to a assumed reaction or an assumed effect. And it's that unknown that we really need to get to.
Yeah, I always think when somebody asks me that question that they're really asking what percentage of babies are exposed to drugs. And,
Mm-hmm.
then people say in a perfect world, we want a baby that isn't exposed to drugs. So, how would you answer that one?
Yeah, in a perfect world, babies wouldn't be exposed to drugs, right? We wouldn't have drugs. People wouldn't be addicted. Babies wouldn't be exposed. In a perfect world, everybody wants their child to be healthy, but be it a biological parent or an adoptive parent, that's the prayer of most parents is for a healthy child. So again, it goes back to that fear, right? Most people don't know
Mm-hmm.
what it means to have a baby who has been drug exposed.
Yeah.
And yeah, it's going to be different than a baby who wasn't, right? There are going to be different risks. There are going to be different things that we need to look at. But sometimes that unknown is much scarier than the reality
Yeah.
of what we need to think about.
I mean, with anything really, right? I mean,
Yeah.
people are so scared to even start the adoption process because of the
Mhm.
unknown. Do you have any indication as to what percentage of moms are using or what percentage of babies are quote unquote healthy, meaning not, without a major medical diagnosis?
So across the board or just in relation to adoption
In
alone?
relation to adoption.
Yeah. Um, you know, I, I don't know that we have a accurate number right now,
Hmm.
to be honest, and especially in regards to health, right? So we have better ideas about how many have been substance exposed, and
Okay.
we do know that it is frequent. But again, an exact percentage, I don't think we have a great data for, especially in the last few years when things have been a little tougher to follow with some of the changes going on. Um, in regards to different tests or different studies and that sort of thing.
Yeah, and I think studies have gotten a lot more in depth too, because I think I read a
Mhm.
long time ago that I want to say 84, 85% of babies who through adoption are healthy. And again, what does healthy mean? Where are they
Mhm.
getting I mean,
Mhm.
it's so hard to do any um, surveys like that in adoption.
Yeah, yeah. Adoptive surveys in general are lacking, right?
Yeah.
We wish we had more surveys in general and more studies in general on children who were adopted, be it about substance exposure or mental health or just health problems in general. Again, we know that in general, kids who are adopted do have more health risks, be it physical health problems or mental health problems. But the numbers change, and we don't have um, a great
Yeah.
hold on what that percentage is right now.
Yeah. Are you seeing any trends among expectant moms having to do with either medical, mental health, or exposures?
So I have a bias here, right, where I'm seeing the most severe probably cases. I'm assuming at least that I'm probably hearing about the most
Okay.
severe cases, right? Moms who are probably using tobacco and marijuana, I'm less likely to hear about in those situations. I'm getting the calls from the families that are considering situations where mom's using methamphetamines and fentanyl and marijuana
Hmm.
and in a variety of things. So what I'm seeing is a lot of methamphetamines and fentanyl. I would be willing to assume there's still a lot of tobacco and marijuana out there also, but that's an assumption because I'm not particularly seeing it. From a mental health disorder side, lately I've seen a lot of bipolar questioning there. A little bit of schizophrenia, not quite as much though. So bipolar seems to be the most common I've been asked about recently. And I'm sorry, what was the last one? Was it
Yeah, just any trends in
any
general,
health needs in general?
exposures, medical, mental
Yeah.
health. So I think you've covered, and it's funny every time somebody brings up when I'm having a discussion about exposures, marijuana or smoking, I'm like, oh yeah, those are considered exposures. I
Mhm.
forget because in the adoption world, it's so common. I barely even consider that because you almost have to be open to those
Yes. Yeah.
things.
Yeah. And that's why I've assumed it's still there, but I'm not the one necessarily
Yeah.
being consulted when it's just tobacco and marijuana.
Yeah.
Yeah.
So when it comes to going through the checklist of criteria, so when you're a hopeful
Hmm.
adoptive parents, you get this questionnaire. What are you open to and what you aren't open to? And there's usually an option. It goes through all these drugs and mental health issues and all these things. And the options are check yes or no. Is it truly that simple to just check yes or no?
Yeah, no, absolutely not, right? It it was that checklist that made me start doing this, that made
Oh,
me start
really?
this business. Yes, yeah. 10 years ago when we started the adoptive process,
Mhm.
um, we were with an agency at that time that gave us a checklist that was just yes and no, and there was no gray area, there was no room for comment. It was black and white, yes and no. And I struggled with that checklist. I
Mm,
hated that checklist.
mhm.
And that stayed with me through the years as we went through the adoption process twice. And then by the time we finished, I was like, if I have struggled with this, how are other families doing it? And that's why I started doing this. There is nothing black and white about these issues. There is so much gray space
Yeah.
and so much nuance to it. It's really a shame that some people were still looking at those issues as black and white and asking those kind of determinations to be made.
Yeah, I mean, when I first started this business 13 years ago almost, everything, all the applications were still
Mhm.
written. And I used to tell my families, just write in, it depends, or write in
Yeah.
notes. But now I don't know if it's all still yes or no, or if there's some agencies that
Mhm.
have like write notes on this side. But electronically, it may just be yes or no. So, hopefully there's an opportunity to have a bigger conversation. You know,
Mhm.
whether it's we want to see them and then discuss further
Yeah.
or, stuff like that. But what should parents really be looking for and asking themselves when they're just starting the process and they have to think about, well, what are we open to? What are we not?
Yeah. The biggest thing that parents need to do is be honest with themselves,
Hmm.
right? What are you able to see yourself handling at this point in time? Maybe you are, this will be your first child, you have a lot of extended family around you, a lot of support, and you can see yourself easily taking in a child with extra needs versus a family that may already have two or three kids with special needs. Can you really add another kid with significant special needs into that mix? Every family is different, and there's not a right or a wrong, right? We all feel badly. We don't want to say no to somebody. We don't want to be open to a situation. But we do have to be honest about what we are capable of and what our comfort level is, right? So that would be step one is where is that level of comfort? What are we really able to do?
Hmm.
Step two is thinking about those biases, right? Asking ourselves about them. Do I have a bias? Do I have a bias about exposure? Do I have a bias about race? Do I have a bias about, mom's history or something else? And again, being honest with ourselves, learning if I do have a bias, where did that come from? And what do I need to think about instead? How do I open my mind up about that?
Mm.
And what do I need to learn? If I don't know what happens really when a baby is exposed to substances and I have a bias because a substance is there, let me go learn, let me go seek more information, let me go ask for help, and go from there, right? If we walk in with a closed mind, I think we only do a disservice to ourselves and to those kids in the future, unfortunately.
Yeah, well, and I think that that's the key point is people don't know what they're open to or not because they don't it
Mhm.
not all the time, and most people come
Yeah,
in with a bias, right?
absolutely.
So I on my intake form, when I'm asking things like what are you open to as far as race, because it really determines what my conversation is with them.
Mhm.
And when they ask me things like how likely are we to adopt, when you're coming in saying I want a white baby, no drug exposure, and I want that baby to be a girl, and blah blah blah,
Yeah,
then that's
yeah.
a different conversation that somebody who marked yes I'm open to everything, right? um
Mhm. Mhm.
but I write in parentheses next to are you open to opioid exposures? I put in parentheses, keep in mind that most white birth mothers are using, or white expectant mothers are using opioids on a daily basis.
Mhm.
And
Mhm.
so when they mark no, and then I might ask them about it on our call, they'll say, well, I marked no, but I really don't know much about it.
Mhm.
And that starts a conversation. So
Yep.
I I'm glad I have that on there because it's their first piece of education about adoption, and they so appreciate the forthcomingness, right, of it, of just learning these things and
Yes, exactly.
seeing if they can overcome that bias. So
Mhm.
let's talk a little bit about prenatal care. Can you? I
Mhm.
never quite, I mean, I've never been pregnant
Yep.
and I
Yep.
never walked through a pregnancy with anyone. What exactly happens with prenatal care and why is it so important? What level of risk is there without it? Which
Mhm.
is super common. Like a lot of expectant moms don't get it. So,
Yeah.
can you tell me about prenatal care?
Yeah,
Thanks.
yeah. I mean, so let me say clearly before we start, prenatal care is very important.
Okay.
I don't want anything I say to be misconstrued that I don't believe in prenatal care or that I don't think it's important. But what is the goal of prenatal care, right? The goal of prenatal care is to support mom and baby to have a healthy pregnancy and a healthy delivery. So, can that happen without prenatal care? Absolutely, right? Happened for millions of years. But during that time, right, lots of women did not survive childbirth, did not survive pregnancy. Lots of babies didn't survive pregnancy and didn't survive childbirth. So the goal of prenatal care is one, to support, and then two, to catch those problems before they become big issues, right? So, with every pregnancy, every pregnant woman is at risk of complications from a pregnancy. People who have high blood pressure or diabetes or other problems prior to becoming pregnant can have those problems worsen during the pregnancy. And we all know that things just happen, unfortunately, sometimes for no rhyme or reason. And that's really where the prenatal care is so important, to help monitor, to help track, to help find those issues so that interventions can be made as early as possible to again support things, to treat things, and to help good outcomes at the end of the day. The longer things are left untreated and the longer they are not recognized, the worse the outcome can be.
So
Um,
what exactly happens during prenatal
yeah.
care visits and how often is it and what does the doctor do or
hmm
Mhm,
So it depends on where they are in the pregnancy as to all of that, really, right? So early on in the pregnancy, the mom's not going all that frequently.
mhm,
They're checking the baby's heart rate, they're measuring the uterus size. Those things will happen at almost all of the visits.
mhm,
They'll be checking urines at various times to see if there's signs of different kind of proteins or different things in the urine coming out, which can uh, be signs of preeclampsia, looking at blood pressures along the preeclampsia line also. At some point during the pregnancy, they check the sugar, and they're going to look to see if the mom is developing gestational
Mm.
diabetes. And then there's the period too of looking at all the prenatal screens, right? So is mom's going to get tested for STDs and appropriate treatment if those are found. Um, Depending on the different situations, there may be concern and reason to do genetic testing. And then that's helpful to know ahead of time
Mm.
so that you can, again, plan for what will come after birth and get yourself prepared and start to have the pieces of the puzzle in place for next steps at delivery. So, various things along the way. As the pregnancy goes on, the visits become more frequent and the testing becomes um, more involved, shall we say.
So it's mostly testing to make sure baby is okay and mom is healthy.
Yeah, it's a
Um,
lot of testing and monitoring. Yeah.
okay. And then she takes vitamins and stuff too
Hmm.
that the doctor prescribes. What is that good for?
So prenatal vitamins, there's a lot of different things in them. A couple ones that we really worry about. One is iron. Iron is mainly for mom to keep her healthy, to keep her blood counts up during the pregnancy, which is really important for her. And then folic acid is a really big component of the prenatal vitamins also. And folic acid is important because it helps to prevent what are called neural tube defects,
Hmm.
which are spinal cord and spinal cord problems, which can affect developmental abilities as we get older in life.
Okay. Okay. So it, it is kind of scary
Yeah.
because it's way more unknown when a mom doesn't have prenatal care. Um, And it's very common that moms
Yes.
don't have prenatal care. So,
Hmm.
is there anything that we should be asking or, usually they'll have at least an ultrasound.
Hmm. Hmm.
Um, is there anything we can do or ask or is it
Yes.
just kind of yeah, what do we look for outside of she's not getting prenatal care?
Yeah, it's hard in that
Mhm.
situation, right? You can ask all kinds of questions. How much you're going to get an answer is the tough part,
Yeah.
right? It's easy to ask, are you taking prenatal vitamins? A lot of women know that if they become pregnant, they should be taking prenatal vitamins. They don't necessarily need a doctor to tell them that.
Mhm.
So that may be something that a mom has started on her own,
Mm.
knowing that she's pregnant. The ultrasounds that they get in these situations a lot of times are just an ultrasound that prove a pregnancy.
Right.
They're not necessarily looking at the heart and the liver and the brain and all of that. Um, Asking mom if you can find out what medications she's taking.
Okay.
I like to ask about that because if she's not getting prenatal care, and let's say she's on a medication for seizures or something,
Hmm.
if she hasn't been checking in with a doctor about the pregnancy, and she hasn't been checking in with her doctor about the seizures, it may be, maybe she just saw them 3 months ago and she got pregnant 2 months ago.
Hmm.
She might be on a medication that could affect that pregnancy that no physician knows about, that no medical professional knows
Mm-hmm.
about. And so that's an important one I like to think about that may not be as obvious in these situations.
Does anything as far as genetics or, I mean, substance use, I can imagine the answer is yes.
Yeah.
But
Yeah.
anything as far as genetics or mental health or anything that plays a part in the forget about exposures to drugs,
Mhm.
um, that might play a part in a riskier pregnancy itself if she's not getting
Yeah.
prenatal.
Well, let's think about what makes a pregnancy healthy, right? Prenatal care helps support it,
Hmm.
helps find those problems,
Hmm.
but nutrition,
Okay.
right? Proper nutrition is something that we know is very important for a healthy pregnancy. Mom herself has to have good nutrition to be able to supply the baby with good nutrition. So if mom's not having the healthiest diet, we know that that can affect the baby's stress, um, instability in different living situations, housing, that sort of thing can also indirectly affect a pregnancy, right?
Hmm.
So, in general, if mom is having more severe mental health issues or more severe, physical health concerns either way, or has a genetic issue herself, all of those things may be affected
Mm-hmm.
that, again, we know are important to a healthy pregnancy. So yeah, certainly if you can find out, where is she living? Is she eating? How much weight has she gained during the pregnancy?
Mm.
That's sometimes a good indication as to if mom's getting nutrition or not.
What do we want to
Surprisingly,
see as far as weight gain?
it's variable. So I wouldn't put a certain number on it, because it all depends on how much she weighed beforehand too,
Okay.
and where her status was before. Was she underweight? Was she normal weight? Was she already overweight? Those type of things. So it is a little bit variable there. But, if somebody's several months into the pregnancy and they've only gained like a couple pounds,
Mm-hmm.
then that's going to be an indication that perhaps something's not quite as optimized as it should be.
Okay.
Yeah.
All very interesting. And unfortunately, we're not talking about women who are working out
Yeah,
every day and eating healthy and
absolutely.
have
Yeah.
a non-stressful life. And that's not
Uh-huh,
what
uh-huh.
adoption is.
Yeah,
And also, these babies are so resilient. I never knew
absolutely.
how resilient babies could be. Okay. I'm
Yeah.
going to kind of ask you, because I know that people listening want to know the effects of this and this and this. So I'm going to kind of go through a speed round with you, as speed as we can get, with getting,
Sure.
without getting into the nitty gritty, but giving us enough information that we can make a little bit of an educated decision.
Mhm.
What is considered an opioid, and what are the risks to a baby?
So opioids are essentially medications that are derived from the poppy plant, right? So they can be directly derived or synthesized to mimic those chemicals in the poppy plant. Opioids, from a short-term aspect, are ones that are relatively highly associated with more severe withdrawal in a newborn. So that's something that's a little bit more unique, I should say,
I like
to the unique.
uniquer.
Yeah, right. Either way, we'll just make up words. A little more unique to the opioids. And then in the long term, amongst many problems that can happen, some of which are not as severe or less severe, but most commonly, we'll see ADHD and executive functioning problems with the opioids.
Um, I often think of opioids as pain pills.
hmm So heroin, oxycodone, OxyContin, fentanyl, a lot of times they are, and that's what kind of started the opioid epidemic, right? It was or at least the proposed start of the opioid epidemic, let's say that, the overuse of pain pills for actual pain that caused addiction in people. But yes, they are typically used to treat pain in a medical type of situation.
Are all opioids created equally as far as the effects that it has on a
Yeah,
fetus? Okay.
it's a great question, right? So, the answer is probably not, but not fully known, right?
Mm.
So methadone is used to treat opioid use disorder, and it's essentially an opioid.
Mm-hmm.
Um, it's seeming to have a better outcome overall in comparison to something like, oxycodone, right?
Mm.
Fentanyl, as often as we do see it right now, is not well studied at this point to know. We lump it in with the other opioids. We assume it's going to do the same stuff as the other opioids, but we don't have great data to prove that right now. So it's a no with a little bit of a we'll find out in the future.
Okay.
Yeah.
All right. What's the difference between methamphetamine and amphetamine?
Okay. So methamphetamines and amphetamines are in a class of drugs called stimulants. So the amphetamines are things like Adderall or Vyvanse, and are used in treatment of medical disorders. In particular, the most common is ADHD. So that is one that's going to come, and be medically prescribed for a reason. Methamphetamines is a very similar stimulant, but it's completely an illegal drug. It is not something that's used in the medical establishment. It's in most cases considered to be more potent than what we see medically prescribed.
What are the risks to the baby and is it the same risk for methamphetamine and amphetamine? And methamphetamine is often referred to as meth.
Yep. So the risks of methamphetamines and amphetamines are in a lot of ways similar to the opioids. Um, they have a little bit less likelihood of getting to the point of severe withdrawal needing treatment in comparison to the opioids for a newborn. They also have a little bit of a higher, stronger effect on the placenta during pregnancy. And so there can be, some extra complications during the pregnancy itself secondary to that. So those are a couple ways that the methamphetamine and the amphetamine stand out outside of the opioids.
So do you think, is it more of a concern for you than opioids?
It depends, right? I always tell families it depends when I'm looking at these situations on how much mom's using and where she's at, right? So the uterine concerns the umbilical cord concerns are not common, but they do happen here and there. And so if I'm looking at a situation where mom is early on in the pregnancy and she's using a stimulant, so cocaine is a similar stimulant, right? Okay. So if she's a heavy cocaine user, a heavy methamphetamine user, and it's early in the pregnancy, I would be more nervous about that than if she was 35 weeks. Because at least we've gotten through most of the pregnancy, and some of those umbilical cord issues are less likely to be an issue at that point in time. So that makes me feel a little bit better.
Okay.
It's, again, it's all how you look at it, and it's all relative. I always say everybody has a different risk tolerance. And that, going back to that initial conversation on fear, what is your fear around this? So it's not a one size fits all answer for everyone.
Never is, which makes it so fun. Most birth moms, as we mentioned, are either smoking cigarettes, and not just one or two, usually half a pack to a pack a day, and or marijuana. Is this a concern?
So that's a great transition after that last statement, right? So again, it's a risk tolerance, right? Tobacco, marijuana, they're not going to be completely benign. We know that, right? There are going to be some challenges and some changes with those, but in general, probably less of a risk for significant long-term concerns than maybe some of the other drugs that we've already mentioned. Having said that, the studies on marijuana were done on kids who were born in the 70s and 80s for the most part. So that marijuana that was there at that point in time is completely different than the marijuana that's out there now, right? The THC component in marijuana back then was maybe a single-digit percentage. Now you can get marijuana with THC 50% or more. And so again, we're comparing in some ways apples and oranges, right? Yeah. And the question is going to be, is that something that we do need to worry about or not? And that's a question mark right now. We don't know what this marijuana is going to do in 15, 20 years, right?
Wow. I never thought about that. So when we say, oh, it's one thing to say, oh, all of our moms used to smoke cigarettes and grandparents or whatever growing up. Yep. And even if we said, oh, and they were smoking marijuana too, it's very different than today.
Yeah. Okay. Yeah. And the biggest studies were done in the 70s and 80s. It's been a long time now.
Are there any studies in the mix right now being done?
There's always studies out there trying to get started, trying to get funded. It's a tough time right now to get studies funded and to keep things moving forward. So fingers crossed. We'll have lots more information in the future about all this, but it's going to take time.
Wow, it's fascinating. A glass of wine here or there, a drink of hard liquor once a week or 5 times throughout the pregnancy, a couple beers. Is there a difference between any of that when it comes to alcohol exposure?
This is such a tough one, right? I wish I was able to say 1 beer a day is okay. 3 is not. But the truth is, it's a gray area. Alcohol is alcohol, right? The little part of the alcohol, ethanol that we drink is going to be alcohol. That's not going to change. The chemical basis of it isn't going to change, whether it's beer versus liquor versus wine. But certainly the concentrations are different in all of those. And in general, reasonable assumptions to make when talking about alcohol or any other substance. The more somebody does it, the more often they do it, the longer they do it for during the pregnancy, the more likely you are to have an outcome, right? And so when we know somebody is drinking very heavily, very frequently, throughout most of the pregnancy, we're going to be worried about true fetal alcohol syndrome, right? What we used to call fetal alcohol syndrome years and years ago, with facial feature changes and significant learning disabilities, behavioral problems, etc. Now, though, over time, we've learned that it's not just that syndrome, but more of a spectrum. And some people are not as severely affected as the people who we've previously, had labeled fetal alcohol syndrome. So now, with that understanding that there is more fluidity there, more, of that spectrum, more of a, gradation.
Mm-hmm.
Where does that mean that moderate drinking falls or mild drinking falls? We can't give those cutoffs that I wish we could. Absolutely.
Well, I mean, because we all hear about, oh my God, I got wasted and then I found out I was pregnant, and those babies tend to do okay.
Yeah. Yeah.
And then we hear about, well, in Europe, drinking red wine is okay during pregnancy, or, right? Isn't it in some
Yeah.
places in the world, maybe Italy? Um, ah, come on, Dr. Silvestri, you got to have better answers than this.
I'm sorry. I wish I had them. I really do. Yeah.
All right. Then we'll
There's
move on.
just not that clear-cut answer, unfortunately.
All right. What about with hepatitis? I know there's different types of hepatitis. What are the different forms? What are the risks, and how does it manifest in a child who actually gets it? Before we go on, we're going to take a quick break, but don't go away. We still have so much to talk about. Hey there, Adoption Roadmap fam. Are you ready to take the next step on your journey to parenthood? If so, head over to our website and take our quiz. It's called, Are You Ready to Adopt? It's not just about testing your knowledge. It's about making sure you're emotionally and practically prepared for the beautiful, complex journey of adoption. Let's make your dream of parenthood a reality. Go to rgadoptionconsulting.com and take the Are You Ready to Adopt quiz today. That's rgadoptionconsulting.com. The quiz is free, and it will let you know where you are in the process and if you're ready to jump into your adoption journey. What about with hepatitis? I know there's different types of hepatitis. What are the different forms? What are the risks, and how does it manifest in a child who actually gets it?
Yeah. So the two big hepatitis that we would worry about during a pregnancy would be hepatitis B and C. The good news is that B is not real common in general in pregnant women, and C is not real common either, but it is certainly more common than B. And unfortunately, there are some indications that it's a little more common than we would hope, let's say that. So anytime hepatitis B or C is present in a mom, there is the risk that that can be transmitted to the baby. And then if the baby were to be infected with Hep B or Hep C, there's the risk that the baby could go on to having chronic infection, which could lead to significant liver problems, to the point of liver failure, needing a transplant, and or liver cancer in the future in their lives. So they are pretty significant risks. The good news is, if mom knows that she's Hep B or Hep C positive, we have great treatment for it. And the treatment really does decrease the risk of transmission to the baby. If mom has Hep B, and even if she's not treated, there's good intervention that can be done if it's found at the time of delivery, and the baby can be treated then too. We have good medications for Hep C if we do get to the point of needing to treat, but there are some kids who don't respond. So there is still that risk there. But thankfully, we're in a situation now where because of these medications and because of these treatments, outcomes do look better if mom is aware and getting treatment.
Is Hep C associated with drug use?
It can be, yes. Yeah. And that's something I always try to encourage families to ask at some point if they see a situation and mom is using a substance, is asking how that substance is being used, if it's one that could be injectable, right?
Mm-hmm.
So if it's a pill, it's a pill. They're probably not going to get anything in that terms of an infectious disease from a pill. But if it's something that she's injecting, it's or could inject, it's important to know if they are and then what their hepatitis C status is, as well as HIV, right? That would also be something we would worry about with the different drug exposures based on the mechanism by which the person is using the drugs.
Yeah, I think I've seen HIV in a mom once.
Yeah,
It's very rare these days, thankfully.
it is, thankfully.
And do you know what the percentage is? Because I heard it's pretty low to pass it on. And does it matter if it's one parent or both parent?
So if so mom herself would have to be infected, right?
Okay.
So if dad is infected with either HIV or Hep C or whatever, if he does not pass it on to mom, then we're in the clear.
Okay.
Okay. Mom herself has to have it. Um, with so it depends on if mom is being treated or not as to what those percentages are, right? So there's HIV, let's say, um, there's a new campaign out for HIV. U equals U, which means undetectable, is untransmissible. So when we're talking about HIV and hepatitis C, one question that we ask is, what is your viral load? Your viral load tells us how much of that virus is in somebody's body. With treatment for both HIV and Hep C now, we can get those viral loads to zero, essentially.
Hmm.
And so that U equals U for HIV is saying that if you don't have virus that's detectable in you, you're on medication, your viral load is essentially zero, it's undetectable, you're not going to be able to transmit that. And the same general thought process, follows for hepatitis C. If it is so really, really low that it's not real detectable or their viral load is, minimal, your chances of passing that on to the baby is going to be much, much lower. Now, if they're untreated, if their viral loads are really high in the millions, in the 100,000s, then yeah, those risks are going to be higher. They're going to be something that is a true risk for that baby. It's still not 100% by any means, but they are going to be enough to be reasonably worried about and check afterwards and be paying closer attention to or intervening on than if the mom was appropriately treated.
Yeah. Okay. What is NAS?
So NAS is neonatal abstinence syndrome.
Okay.
And it's a term that was previously used to discuss babies who were having withdrawal symptoms and who needed to be treated for their withdrawal symptoms.
Mm-hmm.
There's a newer term out now called NOWS, neonatal opioid withdrawal syndrome.
Oh.
And I like that a little bit more because it really does stress the association of the withdrawal to the point of needing medication with opioids, which is going to be the primary player there. Just about anything can cause some withdrawal symptoms, including tobacco and marijuana and antidepressants and caffeine. But it's really the opioids that get us to that point of needing treatment for that withdrawal.
Okay, so what does care and treatment actually look like in the hospital for nows, and
Mm-hmm.
which I'd never heard of, and also how can parents be, or what should they do to be emotionally and practically prepared for
Yeah.
nows?
Yeah, so to get yourself prepared, right? This goes back to that other conversation where the more somebody uses, the more frequent they're using, etc., the more likely you are to see this outcome, right? So if
Mm-hmm.
you have a mom who's using opioids pretty frequently and at, decent amounts, I would prepare myself to have a baby who is withdrawing. As I mentioned, the other ones may not do it quite as much, right? But if you add 3 or 4 of them together, it is a cumulative risk, right? So when we start adding more things onto the opioids or even just together, you can still have that risk of having withdrawal to the point of needing treatment. So when a baby is born, and we know that there was substance exposure, which is a question mark. Sometimes we don't know, right? But if we do know that, the vast majority of hospitals are going to monitor that baby for a minimum of 5 days. And they're going to look to see if the baby is showing signs of withdrawal. Withdrawal can be tremors. Withdrawal can be high-pitched cries and irritability. They can have feeding difficulty. They can have diarrhea. The list goes on and on. And as they're monitoring these symptoms, they're kind of calculating, okay, if they have so much of this versus so much of that, how severe is the level of withdrawal? There is a movement to going away from treating these babies with medication. So we are seeing more and more hospitals starting to really push kind of the comfort care measures, a lot of skin to skin, low lights, quiet rooms, to try to help kind of comfort these babies and keep the severity of symptoms lower. Some hospitals are really pushing that, and that is their standard of care. Still, the majority of hospitals are treating with medication, though, if the withdrawal gets severe enough that the baby's uncomfortable. And that's really what they're treating for at that point. So in those situations, they're adding a little bit of morphine or something else back, phenobarbital, different medications that can be used. And it takes the edge off of the withdrawal. And they're treating for comfort to try to get, the baby exactly that, more comfortable. And over time, they're decreasing the dose of the medication and watching what happens to the symptoms. And so the goal is to get the baby to the point that the medication can be stopped and the baby can still be relatively comfortable. Doesn't mean that the baby is done withdrawing. There are many, many situations where the withdrawal will last a month or two. You'll still see some signs of it. So I always tell families that they need to be prepared to take home a baby who is still withdrawing. Have that anticipation right away. And all those things that those other hospitals are doing, the skin to skin, the low lights, the quiet rooms, the frequent feedings, those are what the families need to prepare themselves for into the future.
All right. And I've been hearing more and more of these separate facilities that take babies, so they would be transferred from the hospital to almost like a comfort care facility that specializes in neonatal abstinence syndrome. Did I say that right?
Yes.
Have you heard of these?
There's always, yes and no. I guess to some extent, yes. There's always going to be these facilities for NICU step downs, be it for abstinence, be it for other problems. They've been around for years.
Okay.
And years. I think we're still seeing more of that kind of step down care at this point. I can't say I've seen a lot that are just strictly neonatal abstinence syndrome and not the other NICU step downs right now.
Okay. All right. What's the likelihood that a child exposed to substances, so they have a genetic predisposition already, becomes an addict themselves later in life?
So it's more, in my mind, this is more of a genetic question than a substance question, right?
Okay.
Addiction, the mental health side of addiction, right, is multifactorial. It's a complex disease. We know our life circumstances and different environmental things can impact that. But addiction is one of the mental health problems that does have a stronger genetic component to it. So if mom or dad was an addict, and you can kind of, make some assumptions about that based on some of what you read in certain situations, then that baby is going to have a much higher role or much higher likelihood towards addiction than somebody who did not have that genetic family history. So it is something to be mindful of if you're looking at a situation and it does seem that mom is an addict, that baby will need to be parented differently as they get older.
Does the likelihood increase with the more, people in their family, or the more generations of abuse of substances, is the deeper the,
Yeah.
you know what I'm saying?
The studies really look at like parents,
Oh, okay.
as opposed to going as far back as like multi
Yeah,
generations. Yeah.
that's what I was trying to say.
Hmm. Yeah. I gotcha.
I'm a woman of a certain age. These words leave my brain sometimes.
Yes,
Um,
I understand.
so is there anything that parents can do to help stop the cycle from affecting their
Mhm.
child?
Right. So, as parents, one of the best things we can do is model what we want our kids to be anyway, right? Whether it's in regards to substance use, whether it's in regards to how we control our emotions or anything else. We are their strongest role model in the beginning. After that, I always, and I'm sure you've heard me say this before, I really strongly believe honesty is the best possible, the best route with
Policy?
these kids. Policy, thank
Yeah.
you. Like
See,
you said, certain age, it's
you have
gone.
the
I get
same
it.
thing. Yeah.
Yeah,
Okay.
yeah, I hear you. But I really do. It's whether we're talking about just letting a child know that they're adopted or not, or, talking about their family history. You do it in an age appropriate manner, right?
Mm-hmm.
The little ones just say no to drugs. They're going to hear that. You can keep, saying that. Maybe it's less common than it was when we were growing up. I think some of the
Yeah.
messaging, some of the ad campaigns have changed, but
Yes.
you still, you're going to give that message early on, and you're just going to give it like that, right? And then as they get older, when they really do understand more, you can really just be honest with them. Hey, when I say just say no, it's because if you start, you may be somebody who has a hard time stopping. This is what happened. This is what we're talking about.
Mm-hmm.
Just, being honest with them is so important. And it doesn't have to, be super involved, but it does need to be transparent so that they understand where your concern is coming from. And then, just like any other problem, right? You want to pay attention. You want to keep a close eye. And if you start to see signs that you think may indicate that the child has, started to experiment or is starting to use, you want to intervene as soon as you can.
Yeah. I love that. It is something I never really thought about to talk to families about, although, I'm not in their lives at that point, but um, to guide them. But that's the reason I asked that question, is because I heard you talk to a family about, hey, if you say yes to this, what's going to be really important for you down the road is to be able to have those sit down conversations with your child to tell them, hey, listen, you might not be able to have just one drink.
Mhm.
And that is so powerful.
Yeah. When I have these conversations with families, I like to try to add those things that they may not be thinking about, right?
Yes.
Or you may not be putting in the forefront of your mind. Everybody's worried about, okay, is the baby going to withdraw or not? Everybody's worried, is there going to be a congenital malformation?
Mm-hmm.
Everybody's worried about this, that, the other thing. But we're not always remembering that child's our child for the rest of our lives,
Mm-hmm.
right? And what's going to happen 15 or 20 years down the road may not be what's on their mind immediately at this moment.
Yeah. And just to have those conversations is so important. Um, Tell us about STDs and gestational diabetes. These are also two pretty common things we see in adoption situations. I mean, not as common as cigarette smoking, but we see it. And
Mm-hmm.
I have learned that maybe STDs are scarier than I thought. But
Yeah, it depends, right? It depends on your STDs, and yeah, absolutely, they can be very scary. So we sort of already talked a little bit about hepatitis C and HIV, and
are
those
those, oh,
they are technically STDs. They are
okay.
considered in that category, um, and those can obviously have some pretty severe complications down the road. Then there's the side of things like a gonorrhea or a chlamydia, which are pretty darn common, unfortunately. And for the most part, again, if they're found and if they're treated, they're gone. And we generally don't see a ton of long-term issues. There are some, pregnancy complications that can arise with that. But if mom gets treated, I'm not going to worry about that 6, 12 months down the road. Okay. Syphilis. Syphilis is one that a year ago, had we been having this conversation, I would say that I was really seeing a bump in. I haven't seen it in the last few months, knock on wood, thankfully. I mean, that's a good thing. But who knows if it'll come back here. And again, I get the bias, so maybe I'm just not seeing them right now. But syphilis can be pretty devastating. And it's the same type of thing as HIV and Hep C. We have great treatment. If mom is found during the pregnancy to have syphilis and she gets treated, generally those babies do pretty well. But untreated syphilis, it really can lead to lifelong problems.
With the baby.
Thankfully,
That's
for
being
the baby.
for the
Yep,
baby.
for the
Okay.
baby. And again, it's one of those, like, thankfully, we're looking at a situation where the baby is going to be, born in a hospital, and we're going to be there to intervene. And you can still intervene and improve outcomes early in life. But truly untreated syphilis, like if it was not recognized for some reason after birth, and did not get treated in a, nice time frame, it can lead to really lifelong issues. Yeah.
What about gestational diabetes?
Oh, thank you. Yes,
Yeah.
gestational diabetes. So gestational diabetes is not all that uncommon. In that first, like, early time frame for the neonates, you're going to see babies who are typically bigger than your average baby. Those babies can have difficulty with sugars, keeping their sugar levels in a good range, and they can have difficulties with breathing and some respiratory distress. If their sugars go really out of whack, that by itself then has some complications associated with it too. So those are kind of the short-term issues. But we do know that babies who are born to moms who have gestational diabetes have risks down the road too of diabetes, heart disease, obesity, and some other things like that. So that can be something, again, it's something we need to be mindful of as we're parenting those kids as they get older.
Is childbirth dangerous for moms who have gestational diabetes?
Because of the size of the babies, it's a size issue, right?
Okay.
These babies can be really big. When you hear about, that 9 or 10 pound baby, mom probably had gestational diabetes. It definitely makes some big babies, which it then leads to more complications.
Yeah. Okay. That's so interesting because so much of what we're worried about with all the other issues we talk to are preemies and low weight
Yes.
and all of that. So
Yeah.
there's both ends of the spectrum. Typically, parents don't get to see birth records or medical records, I mean, prior to making a decision. But if a parent is lucky enough to get to look at medical records of any kind, are there any key elements that they should look for?
Yeah. I mean, I want to say everything, right? But I guess if you're going to make me choose some.
Yeah. I mean,
Um,
and also, like, some of us skim it and say, "Oh, that looks really good. I don't need to get a
mhm.
professional
Yep.
involved." What are those things we should be looking for?
Yeah. So big things, I would say, really look for, um, well, I guess thinking of it from a short term, right? From a short term, what is the date of when mom is first getting her OB care, right? You get that idea. Was that prenatal care really delayed or just a little bit delayed? If you're seeing multiple medical records, how often is she following up? And at the end of the medical record, it's going to tell you when her next appointment should be, right? So if her appointment was supposed to be in 2 weeks and the next record you get was 3 months down the road, probably not getting the best prenatal care, right? You can kind of make some of those assumptions. On the more long-term side, most of these medical records are going to tell you mom's health history. So that's nice to know what her health history is. And especially if it's a first time visit, a lot of times you'll get the family history. So again, this may be some of the best opportunity to get the family history for that child. You might have, mom's history or mom's sister or her other children involved in that family history in the chart. So that's great to know. Some of those social things that we discussed, what's mom's housing situation, etc., may be in there in what's called the social history section. So you can get some of that. And then we also alluded to medications before too. they should have a list of what medications mom is taking. And so again, that would be important to look at, because while we always focus on substance, the legal substances, there are medications that can be prescribed that are not the best to have during pregnancy. Thankfully, if she's at the OB should be aware of that and paying attention to it too. But it's always nice to be able to kind of look for yourself and say what's going on and what else is she taking.
Is there anything to look for as far as like how the baby's growing, or any certain numbers of a heartbeat or anything like that?
So a lot of those, you'll get that sort of profile of how the baby's doing with the heartbeat and the lengths and that.
Mm-hmm.
Sometimes at the bottom, it'll give you a little summary.
Yeah.
To be able to interpret that itself is really tough. But at the bottom, there might be a little summary that gives you an idea of what the gestalt is, right, for that. Looking at other tests, looking at the STD testing like we talked about, some of those other screens is really helpful if you can get in those. And a lot of those will also have a normal value next to them, which will give you an idea of what's happening.
Okay.
Yeah. And ultrasounds are tough. Most of the ultrasound pictures you're not going to be able to look at and make out much of yourself. But again, there might be a little summary sentence somewhere in there to tell you what the ultrasound showed.
Well, what I think you should do if you get any medical records is to schedule an appointment with Dr. Sarah Silvestri at the Adoption Doc on IG. Just message her and she will make time for you, and you'll pay her a little fee to do that. And it's worth every penny. So that's what I would say to do. And that's what I tell all of my families to do. I read something somewhere, I don't know if it was on your IG or what, about you discussing medical considerations during ICPC. What did you mean?
So, a couple things, right? If you're going in to an ICPC situation,
and by the way,
gonna,
ICPC is
yep.
basically what I'm talking about is that time after you are maybe back in your hotel room and you're waiting to get cleared to go back to the state where you live, which is a different state than the baby is born.
Yeah.
Okay.
So most times, right, and you can correct me if it's changed, but in the past we always used to say ICPC was about 2 or 3 weeks to get through it. I always warn families, right, if you're going into a situation where you really think that baby might be premature and needs some extra time in the nursery, or a situation where that baby's likely to withdraw and again needs some extra time in the nursery, ICPC is going to extend, right? You're not going to start that until the baby's discharged. And so you need to prepare, instead of 2 to 3 weeks, maybe prepare for 4 or 5 to be somewhere. So that's just a mental thing that they need to kind of wrap their minds around in certain situations. The other side then, right, is that after the baby is born and you are waiting out that ICPC, there's things that come up that need to be done. You need a routine medical visit in most situations. Depending on where the baby is born, if it's a boy, some places the OB, while you're in the hospital, will do the circumcision for that baby. Some of them will not, and you have to follow up with somebody a couple days after you leave the hospital. There are situations, unfortunately, that arise. Every baby gets a newborn screen, and that screen goes off to the state and looks for, it's state dependent, but usually 20 or so different medical problems. And if something comes back on that baby's going to need to be seen pretty urgently. So it's good to get a lay of the land a little bit before you go somewhere, and then also kind of keep those things in mind while you're in the hospital and talking to the doctor who's taking care of the baby in the hospital. Hey, I'm going to need a follow-up visit because the agency wants me to get that within the next week. Can you help me arrange that with your office? Or, I need that circumcision, that sort of thing. If you're moving around the state, it gets to be a little bit more difficult, right? So I know families who have done that, where they can move within the state, but now they're 4 or 5 hours away from the hospital where the baby is born, and they're scrambling to find a doctor who will see this baby without having been involved in the initial beginning. It's not to say it can't happen, but it is a little added challenge. It's something that you need to think about before you drive 5 hours.
For sure. And I'll say that typically what happens is when you are discharged from the hospital, that hospital is going to tell you, call
Mhm.
this particular pediatrician's office and schedule an appointment for 2 to 3 days from now for your first appointment. That will always happen before you are able to come home. And you'll also need a doctor's note to, if you're flying home, to
Mhm.
be able to
Mhm.
let that baby fly, because some
Yeah.
airlines will ask you, and I guarantee if you don't have that note, they will. Usually they don't, but if you don't have it, they will.
It would be the time they do. Yep.
Yes, and you also want to get all your records from that
Yes.
appointment to take
Mhm.
home with you. Um, Otherwise, if you have a longer stay in the NICU, you might not have, I don't know, that then gets a little trickier, because ICPC technically doesn't start until after the baby's discharged, and you'll be there longer, so you might have to come back a few times, or you might, if there was a chance that they got it done quickly and you're able to go home right from the hospital, that's a different story. But they'll usually guide you as to what you need to do. And hopefully ICPC is only 1 to 2 weeks, but if they're,
Well, that's good.
if you know your baby's going to be in the NICU because of withdrawal, always plan on 3 to 4
Mhm.
or more sometimes. But
Yeah.
so now parents are home with their baby. How can they find and choose the right pediatrician, if there's a right pediatrician? Maybe who understands adoption or trauma informed care or the complexities of prenatal substance exposure. What advice would you give to an adoptive family?
So I would suggest first starting early, right? If you know you're adopting, if you have matched, if you want to start now when you're just looking, it's fine to go ahead and start that search. And most pediatricians will do a prenatal visit. They call it a prenatal visit, where you're able to go in to the office, have an appointment, just like if you were going for a concern, and they'll tell you about the office. They sometimes will give you a tour. They'll tell you their policies on, do you see the same person every time? Do they rotate and you see different people? What hours are, look at the practical stuff. What hours are they open? Do they, are they convenient for you? So definitely check out the practical side, and then simply ask them, right? Who here has experience with adoption? First, they're all going to say they do, right? Every
Mm-hmm. I
pediatrician
was
has
just thinking that.
experience with adoption. Every pediatrician has experience with kids in foster care. We all do that. But, it's okay to ask more questions. This is your opportunity. What has your experience been? Do you have any special knowledge about adoption? Do you have any special interest in adoption? Does anyone in the group do? Because even if, some of these groups now may have 10 or 20 different pediatricians, and
Mm-hmm.
while that person you're speaking with may not, but their colleague down the hall does, right? And so you know that you can get into a group that has somebody there who's more of an expert.
Mm-hmm.
You mentioned trauma-informed care. That's my second question. If I can't get somebody who has a real adoption focus, because not all of us live in areas where there's tons
Yeah.
and tons of doctors around, right? Trauma informed care is a nice substitute, right? How much do you know about trauma informed care? Have you taken trauma informed care classes? Are you
Mm.
certified in trauma informed care? Lots of different ways to ask that. And that has become more and more popular now. And unfortunately, in some ways, more popular than adoption medicine. So it's probably easier to find a pediatrician who has some extra knowledge and some extra training in trauma informed care in comparison to adoption. So that's a nice substitute, though, because a lot of the same kind of principles really overlap for those kids. And so that's a nice substitute. The American Academy of Pediatrics does have a division that's interested in adoption, fostering kinship care. And so on the various state or even the national websites, you can find lists of pediatricians who are part of that council, and find if they have one near you.
That's awesome. Thank you for that. How can is your IG account the best way for people to find you? How can people find you if they want to do a consult with you?
Yeah, IG is great. My email is literally my name here, sarah.silvestri.md@gmail.com. And so that's also a wonderful way to get in touch with me.
Wonderful. And we'll link that in the show notes. There were a ton of golden nuggets here. And if you are concerned at all about substance exposure, hopefully you are leaving with some more information than you started with. Before I let you go, Dr. Silvestri, we're going to do a little rapid fire.
Okay. My brain clearly doesn't work that rapidly anymore.
Well, we'll see. So the first one is a shout out. Give a shout out to one person or organization that has influenced your either personal adoption journey or the work you're doing in adoption.
Well, I've got to give the shout out to my oldest, Tommy. He's the one who, got us started in this whole thing.
That's so awesome. I love that. I don't think anyone's ever shouted out their child. What's one piece of advice you would like to share with adoptive parents or hopeful adoptive parents?
It's such a difficult process. It really is. And the one piece of advice I would give is find somebody to lean on.
Like a consultant.
A consultant is great. A family member is great. A friend. It's not a process that a lot of people have gone through. And so it's not something that everybody can understand. And so if you can find somebody who's been through it to lean on, like a consultant, it's really helpful to have that support. Don't do it alone. It's hard to do these tough things alone.
I always say that. Don't do it alone. What's one thing you wish every adoptive parent knew before they brought their baby home?
Oh, I wish every parent knew this, not just adoptive parents. Parenting is the absolute hardest thing to do. As a pediatrician, I thought I understood parenting and kids. It's not the same. It is so different and so difficult once you get home with that child, but it's really worth it. It is. But be prepared. It's a learning experience, and it's really fulfilling. It's really wonderful, but you will be humbled.
Describe adoption in 3 words.
Oh, now see, that's a hard one. Wonderful, love, worth.
Adoption is not just a destination. It's a journey filled with love, resilience, and growth. Wherever you are on this roadmap, trust in your path, stay open to learning, and always lead with your heart. You already have everything you need to create a beautiful story for your family. And when the road takes unexpected detours, I'm here to help you navigate every turn along the adoption roadmap. Thank you so much for joining us today, Dr. Silvestri. I hope you got a lot out of this episode. If you did, please leave a review and maybe a 5-star rating. Thanks so much. Bye-bye. Well, I hope you enjoyed that episode of the Adoption Roadmap podcast. If you did, I have a few favors to ask of you. First, please hit subscribe so you never miss an episode. And while you're at it, I'd love to hear your takeaways. Please write a review and let me know what you liked. And if you have a question or a suggestion on what you'd like to hear, I'd love to hear that too. Please shoot me an email at support@rgadoptionconsulting.com and let me know what you'd like to hear about. And if you have a question, I may just answer it online. Thanks again for listening. Tune in every Wednesday and Friday morning for a brand new episode of the Adoption Roadmap podcast. Until next time, bye-bye.